All right, the next test is in honor of Thompson, and it's called the Thompson test. And we use the Thompson test to assess for rupture of the Achilles tendon. So remember, when we're thinking about Achilles tendon rupture, we're looking at a couple of things. So remember history, so age and level of activity are going to be two predictive elements. Use of steroids, previous use of steroids or current use of steroids will be a predictive element as well, okay? When you suspect an Achilles tendon rupture, we're first going to inspect the area, okay? So I want to look at the Achilles tendon isolated before I even touch it. And you can see with Kristen, there's really clear definition of the Achilles tendon. You have the space underneath, right? So as we're thinking about subtendinous bursa, I can palpate through there, see if there's any pain, any localized inflammation. If Kristen did have a ruptured Achilles, there would be less definition around the Achilles tendon. You typically will see kind of a wider space filled with fluid or inflammation, okay? So if I suspect Achilles tendinopathy or Achilles tendon rupture, I'm gonna take both of my hands, and again, if you have a much smaller patient, maybe a child, you could do with one, but pretty much with any adult-sized patient, I'm gonna use both hands. I'm gonna grab the most girthy element or aspect of the Achilles or the gastrocnemius soleus complex, and I'm gonna squeeze it. And I want Avery to zoom in on Kristen's foot. So watch Kristen's metatarsal heads. What do you guys notice there? Hopefully you're noticing that without Kristen doing anything, her toes are being pushed farther into plantar flexion, right? That's what the gastrosoleus complex does. So if there's a rupture of the Achilles tendon, there's a disruption of that whole triceps surae complex, then there will be no movement at the foot. Okay, so if I squeeze, nothing happens at the foot, that's a positive Thompson test. If I squeeze, the foot moves into plantar flexion, that's a negative Thompson test. The next clinical prediction rule that we'll talk about in this slide or in this series is our Wells clinical prediction rule for deep vein thrombosis. Okay, so we talked about this a little bit during our pathologies. So Wells clinical prediction rule is what is currently considered the gold standard for identifying DVT in a patient population. So what you'll do is you'll ask the following questions, and each question has a score associated with it, okay? So if your patient has a 1 or 2, there's a 17% chance of deep vein thrombosis. If your patient has a score of 3 or more, it has a 75% chance of deep vein thrombosis, okay? If the patient has a missed identification, the potential consequences are death, okay? So if you're trying to err on the side of caution, always err on the side of caution, okay? We do not want that DVT becoming loose and then creating a pulmonary embolism or creating stroke in our patient, okay? So if you have a patient of a score of 1 or more, you should always refer them to a physician, okay? Physician will generally follow up with ultrasound, identifying if there is the presence of DVT in your patient, okay? So if your patient has active cancer or has been diagnosed within 6 months or is on palliative care, or hospice is maybe a word that you guys are more familiar with, they get a score of 1. If your patient had a recent immobilization of the lower extremity, so think about walking boot, think about cast, those are probably gonna be your 2 most common, or post-surgical immobilization brace, okay? They get 1 point, okay? If your patient was bedridden for more than 3 days or had a major surgery within 4 weeks, they get a score of 1, okay? So the patients that I have used Wells clinical prediction rule on most frequently are post-surgical ACL patients, okay? So they've had surgery, and then they've also followed that up by longer immobilization, okay? Localized tenderness along the distribution of the deep venous system, so the lower extremity, entire lower extremity swelling, and there's that picture in your pathology lecture that shows the swollen lower extremity, okay? We can do calf measurement, so if there's greater than 3 centimeters in difference between the left and the right, that counts as a point of 1, okay? And we measure that one at specifically 10 centimeters below the tibial tuberosity. So it's a very specific measurement that we're taking here, okay? If there's pitting edema in your patient's lower extremity, and if you haven't seen pitting edema yet, it looks a little bit like Play-Doh or soft play in your patient's lower extremity. So you'll find that swelling, you can put a finger into it, and you'll leave a finger indentation or impression, and then it'll slowly fill back up. But you'll be able to actually see the indentation of your pressure or your hand's pressure, okay? If there are collateral superficial veins that are non-varicose, so there's bulging of a vein that's not a varicose vein, okay? Or if there's an alternative diagnosis that is likely or greater than that of DVT, they get -2 points, okay? So examples of that, cellulitis. So cellulitis is an infection of the skin. It is red, it causes localized swelling and localized pain, okay? But they have to be diagnosed by that, with that. That shouldn't be just your clinical assessment, okay? A calf strain, so a calf strain can cause pain. It can cause a little bit of localized swelling and tenderness. And then patients who have post-operative swelling in their lower extremity, that counts as -2, okay? So you're gonna ask your patients these, you may do some measurement, and then you're going to assess what their score is. If they have a score of 1, you wanna send them to their primary care physician, okay? If they have a score of 3 or more, I would encourage you to consider the emergency department or an urgent care, okay? So this is a case that you do not wanna delay care in because of the risk of deep vein thrombosis. The other special test that we can use to assess for DVT that has a very poor sensitivity and a poor specificity is the Homan sign. So what you're gonna do is you're gonna have your patient go ahead and sit in a long seated position or lay in a prone position. I'm gonna have her come to the edge of the table, okay? I'm gonna hold the bottom of the foot. I'm gonna bring her into just a little bit of dorsiflexion, and then I'm gonna squeeze through the calf, okay? If this increases my patient's pain or elicits that same amount of pain, any pain with that, okay? That could be indicative of deep vein thrombosis. Again, the sensitivity and specificity is fairly low. You can hold that squeeze for 30 to 60 seconds to increase the likelihood of catching it. But most of the time, if your patient does have a DVT, as you squeeze the calf, you're oftentimes that patient's gonna say like, yeah, that's uncomfortable. Okay, so it's generally not a super delayed response. Okay, pain in the calf, throbbing. Again, our possible diagnosis is DVT. Again, if you've ever had a gastrocnemius or soleus strain, you'll know that that also elicits the same type of pain. Okay, so dorsiflexion, squeeze of the calf, and I usually will do both anterior and posterior squeeze.